Well, welcome back to the podcast. Thank you for all the listeners out there who are paying attention. I know there's not many of you, but it's nice to have you back. Today, our special guest is Matt Johnson. Matt, why don't you go ahead and introduce yourself, who you are, where you're from, what your experience is, and kind of what realm of healthcare you exist right now.
Well, I like you. Start with a small question.
I make you talk for the first 15 minutes. That's how this goes.
So I'm more of a technology background. I am not a medical professional, and I come from a world of solving problems around, how to do better video interfaces with Apple
Hmm.
Computer or working with a Japanese company, dealing with Western culture and integrating products, or
Hmm.
helping with Honeywell work on technology that ended up at the space station and interesting things like that. And I'm in the Minneapolis area for the most part. Currently, we operate out of our headquarters are in Duluth, Minnesota. So Duluth considered a relatively rural part of northern Minnesota. It's a decent sized city, but not big. And as a result of being in Minnesota, where Life Science Alley is, a lot of crossovers into healthcare, and had a very unique opportunity to recognize significant challenges around patient encounters and staff performance. That led me into the realm of medical device. And that journey is, for a person without a clinical background, we all think we know something, but without that background, it's drinking through a fire hose. But it brings a new perspective of how to approach complex problems, to identify where those problems have existed with technology companies and where they've done well in solving them and where they have failed, and then collaborating with practitioners on resolving some of the biggest challenges that really face every health encounter.
Hmm.
I'll kind of set a foundation of, instead of going into the depth of the experiences I've had prior to starting the endeavor that
Sure.
we do now. Constant and unmanaged misalignment between patient expectation and provider service and provider need. Constant confusion as we see the injection of Google and the injection of social networks, kind of misguiding those encounters in a manner that is creating a very unreliable experience.
Hmm.
And so when we plumbed the depth of what is really going on here, we came up with a model that we call CITE. So that's an acronym, CITE.
Hmm.
The C is for communication theory. So what is it about everybody that is exactly the same? What is their way that we can reliably know a human being, even if they're from the other side of the planet?
Hmm.
What is it that we know that they need to develop a bond of trust, a bond of compliance and comprehension? And in fact, there's a commonality, doesn't matter where you're from, that we can reliably know exists for everybody. But it's very sophisticated, but it's the way we've evolved to work with each other. And so a patient seeking care is going to be looking for these markers. Do I trust the entity I'm at? Can I reliably work with those people I'm communicating with? Am I getting the service I need? And you'd be surprised at how many
Right.
people have a variety of disconnects. This person doesn't come from my background. This person doesn't look or feel like me. This person is irrelevant. I'm not going to want to talk to he or she is going to be an intermediary. I need to get to my doctor, right? And so this is
Yep.
a world of
Yep.
confusion for a lot of patients. And patients, misinformation. They share poorly, will share information, but they're never doing it on purpose. But that's what they need. So can we give, an African American male an African American male experience in a way that helps them open up, or somebody who speaks Laotian? And can we be cognizant of their cultural needs because it's vital to their care plan? The I is for information theory. A provider is a highly trained, educated, highly literate person seeking vital information to help make a calculated decision on the care for this patient.
Hmm.
Can I identify the problem? Can I convey the issue to the patient appropriately? Can I get them to trust my care plan? And can I get them to proceed forward with it after they're out of this environment? And wow, is
Yep.
that hard? This is where
Oh yeah.
everything got wrong. And so the
Oh yeah.
information theory is, if I'm a nurse, if I'm a doctor, if I'm a lab person, I need only very specific information. I don't need it in a form on an EMR. I need it told to me very, and in an actionable manner. I don't care about certain things if I'm the physician that the nurse does. The nurse might need to hear patient in the waiting room has indicated a pain level of 8 and has
Hmm.
indicated an interest in pain medications to help them proceed with their encounter. That patient has the right to that. And it brings that nurse to their side. But the physician may hear something very different. So the physician may get notified, new patient in waiting room indicates stabbing pain, lower left quadrant, onset 3 hours ago, steadily getting worse, no history of surgeries or medical concerns.
Hmm.
That changes the point of view that that provider has. But hey, this person speaks Dene and the doctor doesn't. It's exactly the same if it's me. Exactly the same information that they need. Strip away the junk data and give them actionable information. And before they see me, and if I'm not of their culture, it may say, your patient's a Laotian female, they're there with their family. You should look directly at the eldest male in the room first and begin your communication. It'll help you build that bond that you need.
Hmm.
And then discharge, a really, really well done health encounter can lead to a discharge that's really extremely well done, but it's a disconnect. This particular patient may not be likely to follow a certain care plan because of their culture. This particular patient may live in an area where they don't have access to a pharmacy or transportation, and you may want to adjust your care plan, or they may have a strong faith-based background that you could adjust your care plan and say, there's a subtlety of about an 8% success rate, but if I go this way and they don't follow it, I'm going to have a failed patient. If I go this way and they do follow it, and we'll have a positive outcome. So there's a lot of nuance there too. So that's
Totally.
the CI. The T stands for technology. So it's technology enhanced. It's not virtual. We do not do virtual health. We do hybrid health. And the E is for, enabled. So CITE is really the foundation. And in this conversation, if we can mentally go back to, we are working with the way that humans need to be addressed and how they effectively work,
Hmm.
then the rest of what, Ben, what you have to ask and how I answer would be grounded in that methodology. I hope that's for a foundation.
No, it's a great foundation. I think you did a good job kind of summarizing it. Questions to build off of that are so more kind of nuts and bolts. I mean, how are you connecting the provider to the patient? I mean, do you have just this resource of providers that are available, and you're probably trying to recruit very different looking and different speaking providers, is what I'm understanding.
Yes, and a little bit more about how that operates is we have a way. So CITE is a real thing. So what is a CITE system? What exists in communication theory? I'm going to tell you flat out. A lot of people are aware of it. They just don't know how to implement it. It's not like your practitioners don't know. It's like, how am I going to do that? I'm in a factory of moving patients through, and if I change that flow, it's a very subtle dance. If I slow down my practice, we don't have the economics to move forward, or we have patients suffering. If I speed it
Hmm.
up, we have other problems. And so
Hmm.
it didn't land where it is because of any other reason other than these are the resources I have available and how best to apply it. And so there weren't site interfaces. We had to invent one. And so to invent a medical device that has the ability to engage patients and staff in a very
Hmm.
complex workflow. Hey, it might be ER, it might be primary care, it might be orthopedics, it might be gerontology. These are all different workflows. So how are you going to efficiently make it so that when a provider says, hey, I need this to do this because my physical practice doesn't have a station to stop and do this, or I don't use a triage nurse, right? Well, you have to invent interface. And how do you invent that interface? Well, I would bring up the fact that what we know today, I'm talking to you on a computer. I've had computers since I was in high school.
Yeah.
This is my idea of what technology should look like. In 2007 or 8, suddenly there became a smartphone. There were phones before that did stuff, but that becomes my foundation of reference. In
Hmm.
fact, these are all ways to work with people. Infectious disease concerns, data transmission concerns, inability to do complex interfacing, consumer grade technologies that don't do well or reliably, and OSs that are completely compromised. So we had to invent something that could do this information theory side. So it had to be a way that it would identify a patient's background and give them an experience, not a animation, not a cartoon, but literally someone who is connected with them that uses
Exactly.
hand empathy. You can identify 212 complex emotional states from the brow line alone. You don't know you're doing it, but you're doing it. You've always, and I think all our listeners have heard 90% of communication isn't the words. In fact, that's true. And the more compelling the communication, I'm in pain, my kid's in pain, I'm disoriented. My brain's operating differently in a medical world. It's not
Hmm.
made for consumer interfaces. So
Hmm.
we designed a brand new hardware based on FDA and infectious disease standards. So we have technologies in there that kill 100% of bacteria and fungus on contact mechanically, non-chemically built into the end of the physical plastics. It also
Wow.
kills a broad spectrum of viruses. We can't have a patient hold our system, then hand it to their next patient or the provider and get them sick. This is something people don't think about, but here's a phone that they tell you over and over again, more bacteria than a toilet seat. I'm sad to know I don't think about that every day. Kind of who cares? But it's a medical environment with compromised immune systems, you're going to kill somebody, you know?
Hmm.
In a
Hmm.
world where if I'm going to work with you and you're going to be my PA, which is highly likely in an environment I'll have something like that, and you break my trust barrier once, we're not going to work well ever again.
Mm-mm.
So we need to strengthen your trust, not weaken it by consumer devices. So our device is not only safe, but the data doesn't actually go to China, to California, to be sold, to be monetized. It's 100% closed loop. So when you're like, hey, I want to use your platform in my practice, it is yours. It is the way your practice works. That data goes nowhere except for with you and the electronic medical record. And so,
Yep.
kind of a
This
meandering way
isn't
to say,
sold to the bigger companies. Yeah.
yeah, there's no data going in. You'll see a disaggregate data, de-identified data, but that's not meant for any use other than your practice. And so that's creating an experience of trust with the patient. So where did we start? We started by inventing a new hardware. So we currently designed in our own entity in Duluth, Minnesota, and then manufactured in the United States, some collaborations in Canada, the
Hmm.
only complete digital medical device for purpose built for medical interactions. It's all there's nothing out there. People say, "Oh, so a tablet with my EMR." Not even close. And at the end of the day, healthcare works in this manner. We track how many patients go through how many encounters and see what those outcomes are. I don't care if it's using a device from a EMR, using a consumer device or our device. It doesn't matter what you think, what you can imagine. The fact is that we are running at a 99% accuracy. The next nearest device is at a 73% accuracy. We are across all demographies. The Office of Civil Rights recognizes our entity as the only entity capable of providing civil rights, constitutionally guaranteed civil rights in healthcare encounters, the only one. And so, at the foundation, to answer your question, is a very sophisticated technology that we built from the ground up for medical use. We used it in
Hmm.
military first in Afghanistan, Kuwait, and Iraq in forward activities, but eventually we're able to run through all of FDA pieces, which takes almost a decade, and
Oh
then
yeah.
bring it to market. And then at that point, the experience that a patient has, I will see a middle-aged white male working with me. And this is just because of how communication theory works, not because I think I can overcome differences. It's because there's a whole thing around group awareness. You work better with genetics that match you, whether you like it or not. It's not racism, it's just evolution.
It's just how
And
it
so,
is. Yeah. Yeah.
yeah, now comes to the question of what do I need to know from this patient? Well, this is where healthcare, and this is not originally my background, but got to learn a lot of it. My practitioners that work with us help us guide this. I need to know X, right? Whatever that is. And that there's a lot of junk data that happens in a conversation. Oh, I can't wait to tell Ben that my mom had acid reflux, so I'm not having a heart issue. You're like, yeah, yeah, okay. Yeah, I'm going to continue to pour, but would you please get to the point so we can get to treating your issue? Um, there are certain things we need to know. So a typical encounter is a funnel. Like if you're in we'll just say urgent care or emergency care. I don't know why you're here. You're going to present something, but there are things I need to know. Who are you? What's your age, demographics, and background? I don't need to know anything else initially. I need to get that. Are you a returning patient or are you a new patient? Are you
Uh-huh.
taking medications? Are you experiencing other issues? Can I start
Hmm.
with your primary concern? There
Hmm.
isn't a conversation per se. So let's just say I walk into your practice
Hmm.
and I don't know the name of it, but let's just call it Ben's practice.
Practice X.
Yeah. So your front desk and or some other method will hand me this utility.
Yep.
There's a very, very concise way to hand it to somebody. You and I are going to work together. I'm going to give you a conduit to talk to your provider right now. There's no waiting room. Right now, you're going to talk to your provider. So I'm going to hand you this. If you don't speak English, it does it for you. And when I hold this, it'll say, "Welcome to Practice X. You are now connected to your care team."
Hmm.
See a person like me saying this. If I'm Asian, I'll see an Asian person. If I'm every background, it just changes dynamically. It identify who I am through technology, but it's pre-recorded human beings I don't know it is. It feels real, but these portions are algorithmic. It'll dynamically change based on how I respond. If I'm slow in responding, if I look away, it knows I looked away. It'll adjust. So it becomes very dynamic. But your desire to say, is there a live person sitting there somewhere in the world saying, "Hi, welcome to the practice X"? There's not. There are live
Yeah, yeah,
people
yeah.
on the. And as I begin to say, "Yeah, okay, let's get started," and say, "Okay, we're going to start by finding out what brought you here today. I am
Mhm.
going to work with you to give you every opportunity to share those concerns that have you here now. And be aware, as you do this, I am sharing it with the physician, I am sharing it with the staff, and I am working together with them. And at any point during this, they might pop into this encounter, but you are on your way to your provider right now. You are in your journey to your provider, and you will never be alone when you're here at clinic. I'm here with you the whole way."
Mhm.
And this falls into some other questions like, let's talk first about what is the chief complaint that brought you here today? So this is now, you can imagine a human body walk on the screen. Pretty cool thing about humans, we all look alike. We have the same parts. Show me on this body what is the primary area of concern. While they're going through this, and this is how you get down to it's a headache. It's on the left hand side above my ear. You can see how that, I don't have to explain it. What's happening on the back end? What's happening for you? Well, there's an
Mhm.
interface. It's called the provider cockpit. There's also multi-stream audio. It's all patented. So I see you have an earbud in. You might have an earbud in today at the clinic, and it might just say
Mhm.
new patients indicated this issue, tracking along. That's all you'll hear. Your other staff members will hear something probably different. But if you go into the cockpit, you can see exactly where they are on their journey. You can see if they're stable. You can see if they would benefit from a screening for, brief intervention referral to treatment,
Sure.
if you want to get medication reconciliation done, if you want to get, and you'll see where they are staging in their process. You can navigate and say, you know what, I want you to add a protocol around Columbia suicide because I see a PHQ-9 score that's high, right? Depression.
Mhm.
So you might take 2 seconds to say, okay, I see there's alerts happening on the screen. I got an audio alert. I'm gonna get more information. By the time this individual ends up in an exam room with you, you're going to walk in and you know a lot, and they know you. And this conversation isn't, "So how are
Yeah.
you feeling?" No, "I understand that you've been having trouble sleeping and you have some pain in your left side. We're going to address both of those things today. And thank you for that information." But the real vital part for you as a provider is not only do you know everything about them or cultural background, so you might tell you what their cultural needs are, it might tell you about their pacing and literacy on top of the medical side. You're not charting this. Unbeknownst to the patient, well, they know it, but they might tell them we're charting and everything's happening. You don't go into the chart and add all this stuff. It's already been done. So their social history, their family history, their medical history, their chief complaint, their presentation, their chronicity, all of this has already been done. It's already in your EMR. And so by the time that you're sitting with them, it's already built your credibility. It's already made sure they were never
Mhm.
alone and disregarded. It's already told you what you need to know to make an informed encounter. And so totally different experience. And then the other part is
Oh
that
yeah.
yeah, that it's about you being able to have a time with the patient, right? So it changes your dynamic. And like
I
I
mean,
said, you can move it around all you want. You have control. Go
That's
ahead.
kind
I'm
of
sorry.
why we get that. No, I mean, that's kind of why. I mean, I'll just speak from personal experience as a PA. What you get sold when you go to PA school instead of going to med school is you have more time for patients. You get more time to really like dig into their family history and social history and what their anxieties are at certain visits, or whatever the specialty may be. The reality is that's not the case. If you're already telling, if you're telling providers that, hey, this is accurately charted from the get-go. You don't have to be doing anything. It's already paying attention and listening to everything. And the providers will just celebrate in the background. I mean, I think I did see data from one of your documents on the website just about how much time just that little piece saves right there. If you could just say, hey, this is integrating with software to go straight into the chart note for this visit for this patient, and it's actively being updated while the provider doesn't have to say, okay, I have to remember this and then remember this and remember they said this offhand comment. I got to put this all in the chart once I leave this room. Oh, and don't, and have to forget about everything else, that's distracting me from this patient's visit at the same time. You know,
Yeah.
that's pretty incredible. I mean, it's very unique. I don't know why we haven't made it to this point yet across the board with how much technology has increased and even with the AI, different things coming out. But I'm curious to hear about now that we know kind of what your product is and how it kind of works. Why isn't it everywhere? Why is it only in Minnesota and small parts of Canada?
Well, the enterprise side really kind of entered market in 2016 and entered into medical trials in the Twin Cities,
Okay.
Minneapolis, St. Paul.
Yep.
And you know what people do when they have a new product like this is they say, let's put it in the toughest environment we can imagine. Things like a 72-hour hold in a ER or something,
Yeah,
right? Let's
they're putting a Hennepin ER waiting room.
play right there at Hennepin Health, right? We did
Yep.
that.
Yep.
Hey, let's just know that we have a population that feels very disrespected. We have literacy challenges. We have language challenges. We're working with 103 random languages with refugees with trauma-informed care. Good luck.
Sink or swim.
Yes, exactly. And that's not so much a problem of our product. We actually can succeed in those environments. But
Hmm.
you hit the nail on the head. You're dealing with a very challenged population of patients and staff. In fact, a lot of the places that medical centers operate, they lose money. And they don't have a system set up to be always engaged. A patient never being alone is unheard of. A typical patient experience is I stand in line. I'm in pain. And I get to
Hmm.
a registration desk and it might have a kiosk and I don't know what the hell to do. Or it might have a staff member. And I mean, this is a process. Most of our encounters with our system are done and the patient's on the way home before they even get checked into a normal medical center, right?
Totally.
Well, I built my medical center with an infrastructure, with a waiting room and a sub waiting room, and with a triage nurse, and with a secondary staff, and with an EMR that's guiding how these things have to happen, with a doctor load that's managing these waves of patient volumes and stuff.
Sure.
Changing that is a very, very complicated thing because what is at risk? And I try to help people understand this. If you bring something into your practice and you are going to make a mistake, you may never recover. These patients do not feel comfortable coming back to a place
Yep.
that has disregarded or made a mistake. Or you
Sure.
might have an error that your insurance is going to change. So there is an incredible sensitivity to change.
Hmm.
And these systems infrastructures are built around I'm going to have X number of people hired who do X number of things. And if you come in and you say, try it out here, the person who's trying it out is the person who may have to get a different job, right? Or may have to have a different experience. That's not
Yep.
easy. I don't mean it
Yeah.
in a negative way because there's more than enough work for every practitioner, every staff member. It's just changing everything.
Oh, yeah.
The enterprise, I'll call it the enterprise market space. So big health entities, like Ascension or Mayo or others are very small areas of their practice are actually designed to innovate patient flow. It's just very rare. And
Hmm.
that staff,
Hmm.
there's actually a phrase you've heard it. It's called flavor of the day. You know, what new thing are we going to
Hmm.
try today? And how long do we have to put up with this
Hmm.
crap? Next thing, so they're churning this, and it's hard for them to dive in. So the concept of a pilot is if I don't like it, I can end this. We always do.
Yeah.
Yeah. So we do fine in those scenarios. And I brought up the 2016 to about 2019 as we started getting traction in the market space. And we're fighting against incumbent processes. I really think it's like going into a slaughterhouse for cattle. You're going to go to holding pen to get, it's just weird that we put up with
Yeah.
this 150-year-old model for centralized care. But these are razor thin margins. And in fact, everything up until specialty is probably losing money. And so it's really
It's
hard,
true. Yeah.
yeah, to do something there. And when they want to drive everything into a mammography or colonoscopy or something, right? So pay for their multi-billion-dollar MRI or multi-billion-dollar MRI. I mean, uh,
Yeah. Yeah.
so
Yeah.
it's not as trivial as a person thinks. The world of electronic medical records has been a process of them taking a stake in everybody's medical practice, revisions that happen on an annualized basis that affect the entirety of the practice. And there's a lot of pieces to move in that fleet. So anything coming in is up against a lot of those challenges. When we got to, late 2019, 2020, everybody knows what happened. We had a pandemic.
Hmm.
I don't know that a lot of people, and this is the part that I try to remind people, hey, I went to the doctor and I saw a doctor. Yeah, good for you. They're treating society. And in society are a huge volume of people who aren't in your situation. They don't have the proper insurance. They don't have the ability to communicate well. They don't have the resources you have or will have the experience. Every deviation from the dominant culture, dominant race, and dominant gender is a deviation in performance. And it is a well known fact. And so, for our audience members, there'll be a handful or hopefully a lot. And you start off with not many audience members. These things survive a long time. This might get seen a lot over time.
It might. I mean, this might age really well.
Yeah, I hope so. Well, I do think it will, because we're going to start really headbutting against automation and AI and other things that are
Oh, I
going to
think
be
so. Do
challenging.
you incorporate AI into this product as well?
Well, on the back end for data stuff, but we actually have a patent around what's called swarm intellect. It's a little bit different from AI. We track the performance of practitioners and what do they do well in their interactions with the patient, and then what can we learn from them and share with the other practitioners.
Oh,
There's
cool.
something you're really good at that if I were a practitioner, I'm not, but I'm not, and I'm something I'm good at that and so and it has a lot to do with very sophisticated encounter types. So maybe we have to do identify cancer in a patient and help them understand what their options are. There's not just one answer, there's multiple answers. And how come your patients have better outcomes than mine, or mine
Hmm.
in this area and yours in that area, or you do well with this background, you do better with certain subgroups than I do. And how can we
Hmm.
learn from that and enhance this to tell each other what's right?
Yeah.
Hey, this indications have shown that if you do this additional thing with this patient, they will be more likely to follow the care plan and have a better outcome. So,
Hmm.
and that changes. That changes because society changes and expectations
Totally.
just change and performance of providers change. And so, what you're good at today might not be as relevant tomorrow. You might get better at something else. And so, we track along on those outcomes, and we strongly believe that at the point of care, the tip of that spear is the provider, and they're going to work best with the patient. If we set them up well for trust, compliance, and understanding that patient, we perform better. And if that provider
Hmm.
does something that ultimately yields a better outcome with some groups, you want to know. Other providers want to know. And how can we know this? And that's what we do.
Hmm. And that's I like that. I like that you are able to share that data with everyone else and to continue to grow. I mean, if you become a medical provider, it's I hope that you are in the space where you continue to look at the studies that are coming out about different treatments and different cares and different, whether it's surgical devices and new techniques, that you continue to be on the cutting edge and having a desire to learn. And so I want to learn from my colleague who is treating, for the location where I'm located. If you're on the reservation and treating that patient population, what works best for you and how do you address them and how do you address your patients? What is the most effective way? So let me learn from that so I can incorporate it in my practice. And then, everybody becomes a more well-rounded provider in that sense. And then you're able to give that to somebody else, right?
Well, let me give you a couple of examples that the dynamic reality of healthcare. So we ran a COVID clinic in the Twin Cities, right in the heart of COVID.
Mhm.
We worked with a population somewhere in the area of about 17 languages there. But there was a lot of minority population coming to this health service, and people come in like afraid that they might have COVID. Some come in with likely do have COVID. Some of them are going to be admitted to the COVID unit. Okay, you got a lot of complexity there. And then in the middle of all this, that whole George Floyd incident happened.
Mhm.
That affected that community in a way that I cannot fully explain.
Yeah.
I don't care what you think about the incident. This is the world and reality of healthcare is it doesn't matter. There's no political view here. I have a change in
Mhm.
my population. The way they perceive everything just changed. How do I adapt quickly to that fact?
Mhm.
Well, the unit we worked in had the National Guard in it. So when we went in to help with the service, we had to walk by people with machine guns. Don't tell me that didn't put a chilling effect on the patient population. And we had to
My
kid,
God.
yeah, this is real. And okay, so that sounds like, oh, 1 in a million chance, something like this happens all the time. But another thing that happens is a group of people from Myanmar are brought to this country because they were in refugee camps, and we are a very welcoming country in spite of what people think about immigration. And suddenly you have 5,000 people coming for refugee camps that speak Kaya, Karen, and Karenni. How, and you've never met them before. What are their cultural needs? And we learned this in Minneapolis with the Hmong population.
Yep.
Hey,
Yep.
you're in a birthing clinic and you just do the best practices and you dispose of the afterbirth. You just curse that kid. You know, it's important for them to follow their care plan to be for this. We made those mistakes and that population suffered mightily.
Mm.
And it shouldn't have if we could just make these subtle adjustments. And that's where the swarm intellect is the key factor. It's not AI is lagging behind. AI has to rely upon a lot of other inputs that actually enhance those problems instead of resolve those problems. And
Right.
you hit the nail on the head. I would imagine that you have to read all the time. But what if you read all the time and still missed this stuff? And our systems told you this in real time. Hey, guess what you have in the waiting room or this patient situation? This is what's normal about them, and this is what's unique about them. And here's how you should probably proceed. And you're going to know if things in your own skill set to adjust dynamically. And we're just going to see how you do and then adjust our systems accordingly. In real time, the practitioners are making us smarter. The patients are making us smarter.
Yeah,
And we're
totally.
flowing with the nuance of cultural adjustments. And you would have to be a cold-hearted SOB to think that that's not how you do this, because consequences of changes that are not addressed matter to outcomes and efficacy.
Hmm. Hmm.
That's where and AI comes in on the back end, the data
Kind of the
sets,
compilation of data
yeah. And
or
so
interpretation, I should say, I guess. So,
yeah,
I mean, it's really impressive that I think this is probably the way that healthcare will progress towards. It's just as with anything, the guys I'm talking with on different episodes of medical devices, there's just so many roadblocks. There's so many hurdles.
yeah. Well,
What are the biggest hurdles you think you're running into?
we don't do enterprise health that much anymore. Mostly we just work with a couple major names that you would know because it's too
Okay.
much. It's hard to do change management. The incumbents, meaning the people who operate inside of those facilities and run the systems, are Fortune 50 companies. And the fact of the matter is, a Fortune 50 company is not an innovator. They are a fast follower and they hold back innovation. So it's just really tough to work there. You have to have a very special medical center to make these adjustments. I, in fact, don't believe enterprise health ever will. I believe they're going to get a situation where a new layer of care emerges in communities that happens before centralized care. I think primary care is going to leave those systems and it's going to be, I have to go there because of an MRI or because of a surgery or a specialty. But where they're losing money, other entities have to
Hmm.
innovate to be able to be feeder systems for them and to be able to give that personalized care
Right.
directly to the community, and then be prepared for even a layer below that that's directly in the home. Right. So
Right.
these are layered up methodologies. And so the home part is a little bit of the Wild West, but when they get to that first layer that takes care of their convenience and primary care and refers them out,
Hmm.
that is no longer without complete oversight. And then that is a feeder system up into the major enterprise systems.
Hmm.
Just a
And
theory.
so give me some insight on this. I mean, obviously, this is also helping our listeners as well. Let's say you have small, we'll call it urgent care company for lack like AFC Urgent Care. I don't know if you have them in Minnesota, but they're small private business, but maybe 20 clinics total. Are they going to be somebody that you consider working with, or is it the HCA healthcare, the Healthcare One or the Swedish, whatever the big systems.
Yeah.
Yeah, give me your insight into that.
Well, in 2020, we actually created a second entity called All Thing Health, ALTHING. So All Thing is small rural clinics that are using site method at its peak of its ability, right? So
Cool.
we have been able to place our systems into small communities and provide care that is really unlike anything else. A patient coming in for urgent or primary care will have their encounter in and out on a walk-in basis, an average of less than
25.
25. Door to doctor time, less than 1 minute, typically less than 30 seconds.
Wow.
From patient onboarding into vital sign check and into exam room, usually within about 15 to 17 minutes with a thorough discharge and then out of the door by 22 minutes.
Yeah.
And it's very personalized and it's a model that we have. And the other side of that, and this is a part that we didn't dive into, the cornerstone of All Thing Health is a program for addressing behavioral health concerns in the community.
Mm.
And so you mentioned, hey, you're in Western Canada and in Minnesota, upper Midwest region. The program we do is called AIRS, Assess, Intervene, Refer, and Service. It goes into school districts, into municipalities, into corporations. It holds clinic for a period of days that does a behavioral health enhanced annual visit, so to speak.
Hmm.
And that is national. We operate in every state. So that AIRS program is, seeing we have hundreds of thousands of patients in any given 3-month period that are benefit to this encounter that just becomes part of their day and helps direct them to better care. And I think really any entity looking to enhance their ability to meet those populations we're happy to work with them. It's easier for us to work with those dynamic small entities to replicate our success. We are able to profit in a rural space as a for-profit entity. All thing receives no grants, no state funding, no federal funding. So this is very rare situation, right? So I see
Wow.
it's meant from the federal government. They're releasing $40 billion for rural healthcare. All I know where that's going. That's go
Oh
directly
yeah.
to the major health systems, not people like us.
Yeah. It's the issue.
Yeah, it's perpetuating that problem. But it has a lot of challenges right now. I know that in the forefront of enterprise health is how do we deal with these new income, or these new incursions into our space. You don't know when. So at the end of the day, patients will receive better care from entities. To what kind of touched on earlier is how fast can you innovate? And the question you asked me is, can these small entities innovate with us? And the answer is, yeah, absolutely. And
Totally.
there's no shortage of patients. There's no shortage of need. The bigger question is, can we get enough places to refer and enough places to provide service? That we're very interested in helping other entities adopt our models. So I believe you're at
Totally.
rural Colorado. I
Yeah.
can tell you what happens at COVID. The vast majority of small medical centers failed. The vast majority of those funded by big enterprise systems. So put in your brain, your big enterprise system, right? So it's in Denver, let's just say, or
Well,
major
it's
city.
we'll call it Intermountain Health because
Let's just
that
call
is
it Intermountain
the
Health
big
because I know.
one in the West right now.
Yeah, I try not to name the big brands. I can tell you who did what, but they shut down the rural health clinics. Holy crap! Right in the middle of COVID,
Hmm.
people who need to go to care suddenly had to do the exact opposite of what was indicated. I am a 75-year-old male with immune compromised system. I'm going to drive 2 hours and I'm going to walk into a high volume environment and
Yep.
I'm going to try to get my care. Oh, it was awful. And
Oh
guess what
yeah.
they didn't? They didn't put those systems back in. So there's a lot of shuttered doors in a lot of communities
Hmm.
where they're like, at the end of the day, it didn't meet our money benefit.
Totally.
They go out, oh, we're here to take care of you. When the push came to shove, they shrunk back and they didn't push back up. And so rural America, they need this help. This is a population. They are entitled to this. Around to your question, it's fine. Centralized care has its own economic challenges that make that impossible. Those entities that can flow in and find a way to have a business model that functions is our area of interest. And there's no limit to the town of 800 or 8,000 that has no care, that has a minimum drive of 45 minutes. We can help there. We can do more there, and we can do it on a different model. And it will only enhance the benefit of the centralized care systems because they just lose money there and they can't keep that promise. They want to, they can't.
Totally. Totally. And I just think of the financial burden it puts on everybody else and the time burden. I mean, let me use an example. So I live in a place and work at the level 2 trauma hospital. It's the only major hospital system for 250 miles in any direction. And we've got,
Uh, it's very
oh yeah, yeah. We've got Clinic A down in, you know, the middle of nowhere, 2.5 hours away. And they go into their clinic and the clinician says, "Oh, you're having chest pain." Well, I can't effectively take care of you here, but I can't tell if you're having a heart attack or not. So let me call an ambulance service and call ahead to that hospital that you're going to have to get ambulance support for 2.5 hours away. And then once you get there, hopefully you're still alive, you know? And, but then once you get there, and let's say everything's fine, right? Let's say you're not having a heart attack, there's no other major complications, doesn't appear to be an emergent diagnosis present right now. You're safe and healthy to go home. Cool. Well, I came here in an ambulance, so how do we work this out? Does the ambulance come back to pick me up and take me all the way 2.5 hours back home? Do I have to get a family member to do a five hour round trip and subject them to the hospital, and dangerous travel? It could be winter, it could be snowy roads, could be, you know, elk wandering the streets. So it's there's so many things like this that could and should be implemented. I mean, this is the point of bringing this to light, is letting, our listeners know that these systems exist and good people are trying to implement these things that will help change healthcare for the better. Um, and we're banging our heads against the wall, but
whole
doing the best we
process.
can.
right? The enterprise system is not the villain. I mean, they got us through COVID. They'll get us through the next pandemic. It just sucked for rural entities, right? And so there's no villain here. They just can't be everything to everyone all the time. And we just got a wake up call. And
Mhm.
communities have to take more seriously utilization of frontline services that don't come from enterprise health. There has to be a new way to do that kind of care that persists through an emergency that enhances the ability of enterprise to address those acute cases. Is to your point, if we could effectively do a better job in these rural communities, and then I go one step forward with what All Thing does. Can we go proactively to people and get ahead of it? Can we get ahead of these concerns? If you can go into their day, if you can show up at the school district, 1 in 3 kids is dealing with an unaddressed, unidentified behavioral health concern. You know that
100%. Yeah.
2/3 of adults are having a major behavioral health episode on an annualized basis. The comorbidities and cost of that are more than $1.8 million on average per person. This is a fact. Yes, and it's awful, right? The
Wow.
time between onset of behavioral health concern and qualified care, an average is 11 years. And the time of 11 years with comorbidities, the average cost is 1.8 million. Uh, Substance abuse or a failed suicide attempt or not
Mhm.
taking care of yourself leading into diabetes. This is where
Mhm.
those numbers lie. And
Mhm.
these are people who are feeling disadvantaged or who are not, but don't have the resources to drive the 250 miles, right? Or
Right.
I I don't want to go to the doctor. I literally, your kid gets a bee sting and are they swelling up or not? To your point. Well, I'm in for a 6 hour deal here. I don't want to. If you could change it to say, hey, it's no big deal. Show up. We'll see what it is. I'll get you in front of someone like Ben and he'll find out. We'll get this done. And you're
30,
going to be in it.
30 minutes or
But
less.
you'll show up and do it. You'll do
Yeah.
it because it
Yeah.
has to change. Right. And take another step further, right now, All Thing is treating 103 languages equally. Doesn't matter. Same amount of time, same experience for both the providers
Mhm.
and the patients. Well, there's a lot of rural communities. One of the places we operate is in Austin, Minnesota. There's no reason for anybody to know what it is except for that's where the Hormel plant is. That's where Spam is made, right?
Wow.
If you, if you ever heard of the Jolly Green Giant, right? That's
Yep.
where the Jolly Giant is, Le Sueur over to Austin area. What is this? This is a high labor environment, working with farm, feeding the country. What does that involve? It involves a lot of populations that are brought
Mhm.
over here by faith entities, churches helping people from Myanmar find a new life, welcoming them. And well, how do they always end up clustered in rural communities? Because they don't have services in the rural, in urban communities, because the rural communities don't have services.
Totally.
What they want these populations to blend into ours, to bring economic strength back to the rural world, to embrace not have a problem. And step one, have health care. Your economy without health care, you know, that's hard. That's hard on these people that, we're trying to help become part of our economy, be part of our community. And rural wants, like that community wants this. They want this population to do well. I mean, like I said, the churches go out, they find areas to help, whether in Africa or Asia, and they bring
Totally.
population to welcome them. We don't do service for healthcare. Ouch. You know, really ouch. So, and then same thing's true. Like I said, there's a lot of folks, you hit the nail on the head. I don't want to go. I mean, I can tolerate this chest pain because I just don't want to give up a day.
Yep.
And I don't want
That's
to find
basically
that
how
I
it
got to,
goes.
yeah, I shouldn't have taken that ride. I wasted my money. Well, you know what? You shouldn't feel that way about it. You should be able to get confirmation of you're okay or not, right?
And that's the point of medicine is just to say, hey, yes, there is something going on. We can treat this effectively. Cool. Great. We'll get you to those guys. Hey, there's nothing going on, but your pains are valid or whatever you came in for is valid to get checked out. We ruled everything out. That should make you feel better, right? And granted, there's so much nuance between that.
Yeah. Well, okay. I come in and see you with some chest pains, and you're like, your EKG is fine. You look fine. But the part that I wouldn't have had is that you're going to say, but here's things to watch out for. Tell me more about what you do every day. Okay, maybe you should change this a little bit. Now, I'm not telling you what to do, but these are factors. I wouldn't know it. You know it, right? So now you know me a little bit. I've been given the opportunity to know who you are and trust you. And you're saying,
Mhm.
you know, do this and maybe we can stave that sort of thing off. And when you feel this, don't hesitate to come back. Don't don't say no to coming back. Don't feel
Yeah.
ashamed that nothing. Come back. because it's not going to cost you an arm and a leg. For example, the average all thing encounter being less than 25 minutes costs less than $55. The average encounter in a major enterprise health system is more than $450. That changes that willingness to show up.
Yeah, I mean, people show up to an ER and think, well, there's $2,000 or
Uh-huh.
whatever it may be, you know.
Easily. And
Yeah,
they have to support that. And they don't have a model for it. So, yeah,
$55.
a lot of our patients just pay cash. It's just that much easier for them. They don't even care to do the copay. They're like, yeah, I'll just pay cash and be done with this.
Totally. Yeah,
Yeah.
that makes
And I
total
want to
sense.
I want to emphasize that is primarily for convenience care, right? So more in-depth care can go into, mid hundreds, but that's still less than a third of a typical enterprise system. But
Yeah, I assume if you consider adding on lab work and imaging, then
huh,
obviously the costs go up from there. But if it's just a visit just to kind of set things up or, hey, can you just look at this kind of thing, then it's very affordable and very reasonable.
well, even that, most of the labs that our entity does are about one third the cost of enterprise. And so again, we don't have the overhead that they do. I mean, there's a reason. I mean, they got a lot to maintain, they got a lot to do, and it's just really
Yeah.
probably not the right way to get that help. Yeah, so convenience care would be I have some minor chest pains. I just want to know what's going on. I have a headache and it's persistent. Um, I've strained my neck and it can't sleep. Do I slip a disc? That's a convenience care encounter. And it might end up that I'm going to get some prednisone and go home and track along and the provider will check back.
Yeah.
But hey, they're a simple $55 and my pain is alleviated and I know what's going on and I know how to make sure I follow a care plan and it gets better.
And I felt that I was actually listened to.
I was
Like there was
respected. Yeah.
there was no miscommunication in the whole process.
At the moment I entered the door of this facility, I was progressing my care to the moment I left. I will point something out. Everybody listening, think about the last time you went for healthcare. I will tell you with some degree of confidence 90% of your time there did not involve you advancing your care. There's a rare case where you might have just slipped in at the perfect appointment time. Not likely. You know, it's
And the provider
registry.
was in the perfect mood.
Yeah, the provider's doing the best they ever done. But in general, you're going to be spending a lot of time. There's a reason we don't have waiting rooms. We have engagement spaces, but there shouldn't, look at the real estate that a medical center has to support.
Mhm.
Waiting rooms, hallways, areas of non-encounter is really going to just be about 90, actually probably more like 80% of their total facility size is non-encounter space. Or we're inverse, our encounter space is over 85% of the physical location. A person, if I'm in the waiting room and I've indicated an issue, there's a fair chance that you might just walk out there and talk to me instead of putting me in an exam room because you're like, hey, I can see what's going on here. Let's talk for a minute. I'm going to set you up with a quick discharge. And that's a fast track that I didn't take a space that otherwise is needed by somebody else.
Yeah.
And, there's another question I like to ask practitioners. How many people are in your waiting room right now throughout your enterprise? I don't
Yeah.
know. What's their acuity level? I don't know. You know, how many have been sitting for more than 45 minutes? I don't know. I can tell you at the end of the month when we get our stats. But
Sure.
if you're at one of our systems, I can tell you right now, 100% of the patients exactly where they're at in their process, exactly how many minutes in, how many seconds they've been there, exactly who their treating provider is. I mean, I have through this model 100% visibility of performance in real time. And that's not something enterprise health can do.
No, that's
Maybe they don't.
incredible.
Maybe they don't want to.
Or yeah, I was gonna say maybe they have the opportunity to, but they're just like, no, that's too much. We don't want to spend the time.
Well, no, because if they don't have a patient engagement system that's a companion to the patient, they don't know exactly where that patient is.
I
So
mean,
I could
that's incredible. Big
we
difference.
have 35 patients that are 90% through triage. We have 167 that are currently being seen in examination. We have 25 rolling into the beginning of their encounter. You can see that in real time.
Yeah.
Hey, how many, can for example, hey, we have a patient in waiting room, and you are in Colorado, but this patient's in Southern Minnesota. Ben, can you take this patient really quick? Sure. Pop in. You already have all the data. Your EMR is already filled out. You already have all the summaries. You have all the health alerts. And you can say, yeah, Ben, I'm with the health system here. And it looks like I can maybe help you with the assistance of one of our MAs, and we can get you a care plan and get you out of here right now. You don't have to wait any
I
longer. I'm
mean,
here to move.
yeah, and I think any provider would approach that in the same breath of saying, thank you for doing all the upfront headache stuff so that I can actually focus on treating the person that I'm talking with.
Yeah, exactly. And there's some load balancing too, because
Yeah.
patients tend to come in clusters.
Always.
So,
The bus gets
you know,
dropped off is what we say in emergency rooms.
yeah. Oh, yeah. I mean, people use emergency rooms way too often. If I show up right behind a car accident, what's the point of me sitting there angry? It's people who need help are in 100% focus. You know,
Yeah.
that's
Yep.
tough. And
And
so if I
yeah,
fail, there's things I could be doing, and there's other providers who can communicate with me, say, hey, there's something that has there's an emergency situation that they're being occupied with, but I can help you. I can help you right now. Let's do this.
exactly.
You
Think
know
about
what?
how cool that would be.
Yeah, a patient loves it. A patient absolutely. It is such a disrespectful experience, and it's not intended. Like I said, there's no villain here. It's just
Totally. Totally.
you know, and I wouldn't want those enterprise systems to go away. It would be a hellish world without that.
Give me some feedback, Matt, before we kind of round this out. Give me some feedback about patient reactions. Obviously, you've had a lot of feedback from providers, feedback from healthcare systems and enterprises, but tell me about the patient interactions and kind of the good, the bad, and the ugly, but everything in between of how they review your product.
So in 2024, we set the highest patient satisfaction record for the state. Now,
Okay.
it's a generic statement because there are far larger systems that are vulnerable to far more challenges than us. But I'm proud of that fact that what is different about your experience at one of our clinics? The answer is pretty much everything. And so that's a big lift, right? I'm coming in with expectations. I'm coming into any health center with a history of experience. I might tolerate things better because I've just never had any other option. Does it feel like you just gave me a technology because you just don't have time for me? Or does it feel like you just gave me a companion because you care? And that's really, the difference for our patients. If they show up and they are never idle and they are never alone, it's so easy to get them excited when we
Hmm.
track their performance. So we have the first thing is simple throughput things: time from door to doctor, time from door to exam, time to discharge, any kind of readmission as a result of not thorough enough discharge. These are things that everybody tracks.
Hmm.
But we also track ability to self progress without staff intervention. And so, for example, in our AIRS programs, we go into school districts and we work with kids between 12 and 18. 97% agree to move forward with the program, 100% complete without assistance. We've never had an individual start that behavioral health encounter. Remember, we're asking them about substance
Hmm.
abuse, about
Hmm.
safety, about terroristic threats amongst their colleagues. We're asking them to share and open up their raw feelings about things. 100% completion rate.
Wow.
That's what I said earlier in our conversation. I could say whatever I want about what I think, but the facts are the facts.
Hmm.
The facts are that when we have a health encounter in our facility, the option for a Hispanic speaking patient for our health center and for any other health center is we'll have them moving at exactly the same rate as anybody else.
Hmm.
Exactly. No difference. Ask yourself, what would you choose? Waiting, being disregarded, not advancing your care, or knowing that every second you're there, you are being engaged and this is vital. You're not talking to AI. People don't like automated systems. I don't I don't think we have more than a 100 million examples of can I just talk to a real person? You are
Right.
working with a real person. That's it. So our patient satisfaction runs above 96%, 100% of the time. We never drop below that. Our completion rates still run at around 100%. We call that unaided, meaning nobody came to help. The oldest person we've worked with was for a gerontology program, and then dozens at this age, 104 years old, who do not know how to work with interfaces. This is not a digital interface. This is a experience that follows CITE. It's communication
Hmm.
theory. Person who looks how I want them to look, to work with me, to talk to me, to walk me through, and is patient and gives me all the time I need, is there for me. I gauge my speed. I gauge the depth of information I want to get. And I know I'm always working with a provider. It is not hard. We're not up against a real tough alternative. So we're up
Totally.
against low expectations and we just bring it up a little bit and our satisfaction is very high. But
Hmm.
you had that other word that really at the end of the day is efficacy. And that's important too. Our patients do a really good job of following care plan.
Yeah. Yeah, well, because they trusted the whole interaction, so they're more likely, I think the research would probably show that they're more likely to continue to follow the care plan because they trusted where it came from and they trusted the whole process that led to that.
Yeah, and the provider experience is cleaner, right? Because by
Yeah.
the time you and I are talking, we've already had a conversation. I already know you, you already know me. And you get right into the nuts and bolts of what makes a great provider is I have really good information. I have a very good sense of what's going on here. And I have time now. I'm not charting for the next 2 hours. Tell me a little bit more. Here's what I know from what we've learned so far with together. They're never alone. They're always talking to you in one form or another. Remember, you can listen to the
Hmm.
audio in real time. You can watch the cockpit. You can check it in the EMR. It's all happening in real
Yep.
time. So
Yep.
that,
Every single step of the way.
yeah. And like I said, I think most people enter into a health system saying, I don't care. I'll tell the triage nurse whatever I have to. I need to get to the doctor. Why am I waiting? Hey, the person who went in front of me doesn't look as sick as me. That makes no sense. Or I had an,
Yeah.
if I show up 20 minutes late, they won't see me. But if I show up and they make me wait for 2 hours, what the hell is this? None of that happens.
Yeah. Oh, yeah.
It's it's a relatively easy thing to respect the patients who are model with CITE and not waste anybody's time. So
Yeah.
I would caution to say that as our volumes increase, and they will, we're going to have to stay very tight on that experience, right? There's going to still
Hmm.
be new challenges that we face. We go from seeing a few thousand in a day to a few 100,000 in a week, and
Hmm.
you know we've done a really fine job to this point, and we believe that it scales. And
Yeah.
you know, and the adaptability, I think an earlier question that you had asked is, is it a real person? But what if you say to me, I need to adjust the way I'm adding this encounter because I just changed my workflows? That happens in less than 24 hours across all languages, demographies. It just is that quick. And so that swarm intellect piece and then the guidance of the providers and the facilities is really what's at the core. You're
Hmm.
afraid to innovate in a normal health system because you got to move a fleet. You got to turn the fleet, and that doesn't
Yep.
happen easy without consequences. We try to design a system that can do that. So we
Yeah.
feel comfortable that we're going to continue to set records in patient satisfaction and continue to have a viable model in rural environments.
And once that continues flowing, I have high hopes for you guys. I mean, even just from listening to this, and I hope our viewers are like, starting to bang on their congressman's door or their, state senator and say, "Hey, have you heard about this?"
Yeah.
So, Matt, as we kind of close out, like, thanks for all the info. I mean, really, really enlightening. Where can kind of listeners kind of find out more if they want to do more research? Obviously, I can include links, but are there other kind of opportunities to check you guys out?
Yeah. So All Thing Clinic has a YouTube channel that you can look at. Seeing is believing. We have AIRS events everywhere. So you got a kid in a school and you're worried that there's safety concerns, and you know that at least one third of those kids is struggling with health and suffering in silence. We will come,
Hmm.
show up, and we will help. And we will do
Hmm.
it. Here's what matters. We will come into a school district and see every kid and every staff member, and it'll cost $0. We are partnered with major payers
Hmm.
interested in addressing the behavioral health epidemic. So if you want to see this system make a difference in your community, maybe it's not your kid who's struggling, maybe it is, but sure enough, as kids in that community are, or maybe at your workplace, you would like to see a service come in and give assessment and give people direct ability to communicate with a provider and get a referral. Doesn't matter what state you're in or what city you're in. If you care about the health and safety, we've devised a model that can come and see you. We see veterans all the time for veteran services. We go into districts, we go into municipalities and corporations,
Hmm.
and very, very compelling experience. It takes about
Yeah.
35 minutes of a person's time to get a really good outcome. So I would say look at AIRS, All Thing Airs, and think about the challenges you're facing. Colorado has seen some really terrible tragedies around behavioral health, and they're not alone.
We're probably one of the most infamous states for it,
Well,
but
Minnesota's either one. we
yeah,
had
yeah, yeah, yeah.
flooding in Lake, and we had, so there's trauma. There's trauma from this, and people suffer in silence, and we're here to help. And I am so proud of the fact that the payers, and we're talking like your insurance companies, the Blue Crosses and the
Hmm.
Medicals and the others, they care about this too. They really want to help stem that. I mean, this is as bad, if
They
not
do.
worse. Yeah, and they want to do it in an effective way. This is connecting patients to benefits. So you can look at
Hmm.
the Geacom website. That's a technology company, and look at the L thing piece about our clinics. I would really say that your viewers might want to look into how AIRS might be helpful. And we
Yeah,
collaborate with your
and
local
I'll make sure to
providers. And
post that.
thanks. I really appreciate the time today.
Yeah, I'll make sure to post those different links when this podcast goes live, and hopefully the viewers can kind of follow up with you. Matt, I really appreciate your time today, man.
Likewise. Thanks for the good work.
Yeah. Yeah. All right. Thanks.